I just want to say hello again to everyone and thank you for joining us for today's webinar. We will be learning about just culture. So the webinar today is being recorded and it will be posted to our website. We will send the recording and the slides to all the participants at the end of the series. Okay. I'm Denise Tackett, Quality Consultation Program Specialist with the National Rural Health Resource Center, which is providing this webinar today. We do ask that you turn on your video if you're able. Your video control icon can be found in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. So please remain muted unless you have a question. But to unmute your line, please select the microphone icon also in the lower left corner of your screen. If you dialed in, I think you can press *6 to unmute your line. And you can also communicate through the chat box, which is located on the bottom ribbon in the middle of your screen. We'll be monitoring that and try to get your questions out there. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. This just helps us get a good feel of the audience on the webinar. All right, the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. And the center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where differences are valued. To learn more about our commitment, please visit our website at ruralcenter.org. And this quality series does qualify for ACHE continuing education credits. If you would like to receive credit, Caleb Lazinski will be sending out an email upon the completion of the webinar series. You'll need to fill it out to receive your CE credit. And then please join us for these upcoming webinars or spread the word if you know someone who may benefit from them. Mike Rowland, our telehealth program specialist, will be pulling up the poll. These polling questions are rated on a confidence scale and help us measure knowledge gained on today's webinar. So I see he's got them pulled up. We're going to give everybody a few minutes to, just a few moments to answer these quick questions. The confidence scale is from confident to somewhat confident, neutral, somewhat unconfident to unconfident. So we'll just give you a moment to get that done. And then we will see what the results are. See if we can kind of gauge where we're at the beginning, and we'll do it again at the end. All right, great. So it looks like we have a good amount of people that are somewhat confident, but we have a much smaller percentage at 17% who really feel confident in that fundamentals of a just culture. So on the second question, it looks like we also have a good amount that are in that somewhat or neutral confidence. And then the last question, it looks like about the same. So we have some room and some opportunity for learning and growth, and we hope that's what we get here today. And I feel very confident in that. So thank you for participating in the polls. I would like to now introduce today's speaker, Carla Wilbur. She's an accomplished nurse administrator with a strong background in critical care, education, lean process improvement, and emergency services. She joined Stroudwater in 2014. Carla focuses on supporting rural providers in quality and operational improvement initiatives. She's completed numerous facility assessments and process improvements in quality, care management, emergency department, and care transitions for critical access hospitals, rural and urban health systems, and provider groups. Currently, Carla leads process improvement efforts in the development of the clinical care delivery spectrum and workflow optimization. She is a passionate advocate for combating the opioid epidemic and a leader of the Stroudwater opioid management team. Welcome, Carla, and thank you for being here today. And with that, I will turn the presentation over to you.
Thanks, Denise. I appreciate it. And I'm excited to share with you all today information around just culture. Next slide. So our objectives will be just to kind of define just culture. I know that that's a fairly common buzzword that we have heard in our industry. And then there are programs where people come in and help hospitals build what they call their just culture. But we're going to define that and talk about what it really means. We're going to clarify the benefits of a just culture and describe what is known as 3 manageable behaviors. Explain how the just culture responds to those behaviors, and then a journey to a just culture. So if your organization is just beginning your journey, what does that actually look like? And then we have some case studies where we can walk through the event and what you would have done based on the information that we go over today. Next slide. So this was just an article that I read once about an organization that said, you know, before they started their journey to a just culture, they really wanted to know how their organization would respond to something. So the question was, how would our organization respond to a surgeon who uses an unauthorized piece of equipment in the OR? And then the real information that they wanted to glean from that was, what would be the percentage of respondents to this particular question who believe the hospital would discipline the surgeon if the behavior resulted in no harm or if the behavior resulted in harm? So remember, again, the question was, how would we respond to a surgeon who used an unauthorized piece of equipment in the OR if there was no harm or if there was harm? Next slide, please. So this is what they found. On the left-hand side, you can see the respondents. Now, notice no physicians or managers responded to the question if it resulted in no harmful outcome. So basically, that looked like to this organization, well, they're not going to discipline the surgeon. The physicians and managers were saying no if there was no harm done. 19% of staff said yes, and then 11% of executives said yes. However, if the equipment had caused harm, then we see a big change. 29% of staff said yes, 14% of executives, and then physicians and managers did answer as yes, they would discipline the surgeon if there was harm. So this was their perspective. And that was kind of how they really realized, wow, this is building awareness in our organization that we really do need this just culture journey. Next slide. So the fundamentals of just culture. Next slide, please. So what is it? So the term just culture was really became popular in our patient safety world. And it was by a report that outlined principles of achieving a culture where our frontline personnel feel comfortable disclosing errors, including their own, but maintaining that professional accountability. And, you know, we heard this, if you've ever had any lean training or heard someone speak on lean, lean was basically designed in the Toyota production system. And they gave their frontline staff, so their frontline people, the people that were on that line building those cars, the right to pull the cord and say stop. So just culture is a lot like that, in that we want everyone, including those frontline people, to feel comfortable when they see something that's a mistake or a near miss, to report it. But we don't want it to be considered blaming. So the just culture is one where our organization holds itself accountable, holding staff members accountable, and have staff members that hold themselves accountable. So again, it's a focus from eras and their outcomes to a system of design and behavioral choices. So I always like to say, most of the time it's the process, not the people. Next slide. So there are 3 manageable behaviors. One that is considered human error, completely unintentional, at-risk behavior, where we're aware of the risk, though we believe that it's insignificant or it's justified. So, we know that people typically do not come to our organizations and come to work in the morning saying, or in the evening saying, I'm going to cause harm. I mean, that's just not what people typically do. So there are unintentional errors that are just human errors. And then there are those things that we would consider maybe at-risk behavior. We're aware of it, but it's not really that important. But I've got to do this workaround because the process isn't working right, and I have to get this job done. And then there is reckless behavior, and that's conscious disregard of substantial and unjustifiable risk. Next slide. So when we think about human error is a slip or a lapse, and we'll talk more about what that actually means. It can be an inadvertent action, which is just completely free from intention. And we can manage those through changes in our processes, procedures, our training, design, our environment, and choices. And our response to a human error would be to console the employee and to help learn from this particular human error, which was, of course, unintentional. Next slide. The at-risk behavior, that behavioral choice is associated with the belief that the risk, again, is insignificant or justified. It is an intentional action, but it's unintended outcomes. So we typically, and as this says, drift from known processes to the path of least resistance. So we were talking about earlier, the group, while we were waiting for everybody to kind of join. And I can say this because I'm a nurse. Nurses are famous for a workaround. We will drift from a known process to the path of least resistance if that's what we need to do to take care of this patient. So if our process isn't working right, we're going to find a way to get around it to get this work done and take care of our patient. So some of these examples would be taking shortcuts to save time. And I love this one, speeding a few miles over the speed limit. And it can be managed through removal of incentives for at-risk behaviors. So I say, and people who have been around me hear me say this quite frequently, we need to make it easy for everyone to do the right thing. So if there is something that is standing in the way of doing this particular process, this job, this task, then we need to look at that process and possibly change the process so we can do the right thing and remove that at-risk behavior. We can manage through creation of incentives for behaviors that reinforce a safe learning culture, and then through increasing that situational awareness. So our response to at-risk behavior would also be to coach and to learn. So that take this as a learning opportunity. Next slide. So reckless behavior, That is definitely a conscious disregard of a substantial and unjustifiable risk. This is an intentional action. Examples of this could include failure to perform post-surgery instrument counts. That can be horribly dangerous. Leaving your one-on-one patient alone without ensuring that handoff has occurred. That's a reckless behavior. I had a very dear friend who was a CNO at a facility in Washington, and this actual example happened where the patient was brought back to the unit after being in the endoscopy unit for a test, and the patient had been sedated there, but the patient was brought back to the unit and there was no warm handoff. So the patient was not hooked back up to the monitor, and they were left. Unfortunately, in this situation, that patient resedated, which can happen, and the patient passed away. So that is an intentional action. Now, that outcome, I'm sure the person who left that patient there felt like that, they were safe, but they didn't follow a process that has been set up to ensure that there is a warm handoff from one clinical person to another. So this can be managed through remedial action or punitive action. And that could possibly be our response to this. Next slide. So the three behaviors I'll just summarized here is our human error, of course, is a product of our current system design and behavior choices. At-risk behavior, again, it's a choice that the risk is insignificant or justified. And then the reckless behavior, that conscious disregard for of substantial and unjustifiable risks. Next slide. So what we want to see in a just culture is what you see in the green. It optimally supports a system of safety. If you move to the left, the blame-free culture, no accountability, completely blame-free, we don't have the transparency that we would need. We don't have the accountability, because without accountability, we can't really support our system of safety. If you have a punitive culture, completely punitive culture, then transparency is impossible, because whatever the issue was that happened, if we are just punishing and we're not talking about this near miss or this medical error or whatever the case would be, then no one can learn from that. We should always learn from whatever the situation is, whatever the occurrence is, whatever the incident happens to be. And it should be that we are okay with talking about it at our morning stand-up meeting or our manager's meeting, whatever the case may be, because we want to have an accountable culture that does support safety, but is a just culture. It's not a blame-free culture, and it's not a totally punitive culture. It meets somewhere in the middle where everyone understands that they can safely report errors without the risk of being blamed for that. Next slide. So we'll talk a bit about the just culture journey. Next slide. So to begin your just culture journey, we need to make sure that our mission and vision of the organization is clearly defined for everyone to understand. I have been in large groups before, and I ask, tell me about your mission and vision. What does it mean? And more than not, I hear, well, I know that it's in a frame on the wall when you walk in the hospital, but how many people even know what it says? It's really important that for us to have a just culture and begin a just culture journey, that we have our mission and vision of the organization is defined and everybody knows what that means. We need to engage leadership. We need to set performance expectations. We need to develop a system for what we call high reliability. It's a continuous monitoring of predictive indicators. A high reliability organization is very sensitive to operations. Do not accept just simple explanations. We need to really understand what happened. We need to be preoccupied with failure. Because if things happen along the way, we want to know so that we can change and make it better. That's what a high reliability organization is. We need to defer to expertise, which means we need to have the people that are actually doing the work to help us with the solutions to the problems and the continuous monitoring. And we need to be relentless in our journey. That actually will build a high reliability organization. We need to integrate policies. So if there are specific things within our organization that you find that are not working well, the process isn't working well, how does that look in the policy? Does our policy say that we do XYZ, but we're really doing ABC? The policies need to be integrated. We need to standardize communication throughout the organization. If I've worked with, and I know I have worked with some of the hospitals on this call already, standardized communication for me means SBAR. That way everybody communicates with the same process and same language. We need to build a team to promote our just culture and our change in our organization. And we need to continually learn and grow. If we stop learning, then we have stopped growing for sure. Next slide. We need to set the why. So we need to clearly define our mission and vision for the organization. And once everyone knows the way, they can make decisions to go that way. This will be the foundation many decisions are weighed against. Next slide. So for leadership expectations, we need to have procedures in place for all of our team members to follow. Be aware of opportunities for our team members to drift from the written processes, but be open to redesign. If something is not working, a process is not working the way that it used to, maybe that's because something else has changed. But we need to be okay with saying, this isn't really working this way, and have leadership engaged to help us with this solution about this particular process. We need to ensure that our team members are properly trained. Set the clear expectations up front. We need to offer positive reinforcement when our team members speak up for safety and actively engage in creating a desired culture. There are still, and I was just talking with a hospital day before yesterday, there are still pockets within organizations that the employees don't feel like they can raise their hand and say this isn't right. They're a little bit afraid of that, whether they're afraid of their specific manager, or they're afraid of speaking up because of other people that they work with in their department. Whatever that may be, there's something wrong. And that means that there's something wrong with that entire culture. So we need to offer positive reinforcement. When someone brings something up to us, don't just think of it as the squeaky wheel. There may be something to this, and we need to look into it. And again, who knows better about what's actually happening than the people doing the work? We need to hold our fellow leaders accountable. And our senior leadership is crucial to lead the example of a truly just culture, where this is we're not in blaming, we're looking at the processes and not just the people. Next slide. High reliability. Of course, I had mentioned that Just Culture does support the journey to high reliability, being sensitive to operations, looking at your data, because your data is a tool, embracing transparency and encouraging learning from mistakes. If there are mistakes, then we should all be learning something from them and sharing that as well. Our Just Culture, again, asks us to focus on processes, not people. And through our event investigations, we should all have our thorough investigation. We should make it harder for those behaviors to be repeated in the future. So once we do our analysis, we want to make it easy for everybody to do right thing, make it harder for these errors to occur in the future. Being preoccupied with failure is making sure that we conduct our high risk processes through these different methods of improvement opportunities, and to help us find the root of the problem so that we can avoid future mistakes. Deferring to expertise, as I mentioned before, we need to bring in the people who are the closest to the work to help us come up with that solution approach. Be relentless in your journey. And I love this quote from Henry Ford: the only real mistake is the one from which we learn nothing. Next slide. So policy integration, our policies are used to reinforce and define expectations and actions. Most of our accrediting bodies consider policies to be binding. So we want to make sure that our policies actually do reflect what we are doing, and that the content of our policies are definitely accurate. Policies are also there not only to support staff, but to help our leadership emphasize our commitment to just culture. So one of the organizations I worked with recently developed their just culture policy. So a just culture policy can be an effective tool to communicate the values of cultivating that culture of safety, and improving the staff tools, describing those and improving those, and empowering open and honest reporting. So when they rolled out, part of their Just Culture journey was to develop a policy with their group that they had created, so that they can share the Just Culture policy with the entire organization, and everybody knows that this is the expectation of our organization. Next slide. Standardizing communication. Our communication should include communication that is complete, that communicates all of the relevant information, avoiding excessive details or what is called noise. It's clear, plain, accessible language that can be understood by everyone. Concise, using short, essential messages, and timely. New processes or changes need to be communicated as soon as possible. That gives all of our staff time to get used to those changes in reporting requirements, review the structure or other aspects of our Just Culture process. Next slide. Creating a team to promote Just Culture, we need to have an ideal team. So that is one who understands patient safety culture is local, and that it is comprised of our engaged frontline providers who do take ownership in patient safety. Includes staff members who have different levels of experience. So your team cannot be a team of just leaders. It needs to be people who have been at the organization for a very long time. It needs to include people who have just come in, our newbies. They have fresh eyes. We need to have people on our team that are from a lot of different levels of experience, from leadership to new people who are just entering, possibly entering the world of healthcare at our organization. We need to include those members who are involved. If it is a specific, you have a, for instance, you have a medical error that occurred, and we want to understand why, then we need to bring in the people who were there when it happened so that we can talk through and understand what happened to that with that particular process. Your team should meet regularly, weekly, or at least monthly, have adequate resources. We need leadership support to help with adequate resources, and then have that senior leadership support. We used to call that in our lean work, our sponsor. So if there are things that we need to discuss with a senior leader, then we have that sponsor person that can help us with this particular situation. Next slide. This is just an example of a charter. So a charter defines the purpose, scope, objectives, and deliverables of a team that's focusing on events and implementing just culture throughout the system. So you may have your charter set up differently, but this just is an example of showing, what this just culture event review team is responsible for. What are their purpose, the scope, their different members, objectives, and then the deliverables of the process with the charter in mind. Next slide. So maintenance, and we need to introduce our just culture during orientation. When our new people come in, this is something that should be part of that general orientation, either on your unit or in overall hospital-wide orientation and onboarding, and given examples of just culture in action to help show what our organization's commitment is to just culture. Hospitals can also develop and share standard system change reports with our frontline that shows that the frontline staff, that the hospital believes in addressing system level issues instead of blaming individuals. And earlier in the slide where it talked about transparency on the red, yellow, green diagram, we want to make sure that we're not afraid to share things that we have had to put in place to change because of a patient safety issue or a process that was broken. We should be able to share those throughout the facility. And that definitely demonstrates to a new employee that we have a commitment to changing and improving system level problems instead of blaming individuals. And we want to encourage our team members to challenge the status quo and speak up when they feel there's an opportunity for improvement. The hospital that I was with day before yesterday, they had a discussion around a new person came in and said, why are we doing this way? Where they came from, the process was different, and it was a little bit more efficient. And so they didn't have they have a great organization that believes in addressing, system issues, and in believing that those fresh eyes can sometimes point out things that could be done differently. So we need to encourage all of our team members to say, that doesn't seem quite right. It could work better maybe this way. And they feel comfortable speaking up when there is an opportunity to improve. Next slide. So let's talk about event response. Next slide. So investigation of events. So sometimes our systems don't work as intended. We know that. And any of our undesired outcomes should be fully investigated. So this could be a team of individuals brought together to conduct an RCA, what is known as a root cause analysis. This definitely should consist of people who were involved in the event. A root cause analysis can be done in many different ways. 5 whys, the fishbone diagram, which we've used before, and then reality tree. The RCA should consider that human-centered design principle and factors that impact our human performance. Most of the time, a root cause of an event is not centered, again, around the person, but the process itself. Next slide. It's important that if there has been an event, that we debrief as soon as possible. If we wait another day or 2 or a week, by that time, we've lost some of the valuable information that we can get when something has just happened. So we need to debrief the whole team as soon as possible after the event. It helps us not lose that critical information, and it's in real time, so we can get a better understanding of what actually happened. Now, after that, there is a more formal investigation that follows, but that debrief as soon as the event happened, really sets that stage for that further discussion. We want to make sure that whatever happened, if it involves the patient, that the patient is safe, of course, and stable, and then and the team members have the support they need, but debrief as soon as possible. It should be very quick, no more than 15 or 30 minutes. And it depends on the event, of course, that we would need to review key processes and breakdowns, the patient condition, and information from this debrief needs to be entered into some type of formal tracking or event tracking database. Most of the time, organizations have standardized debriefing forms for certain types of events. So just remembering that the important thing about debriefing is that it's done as soon as we can, so that we don't miss some of the information that we might forget if we wait a lengthy time before we talk about the event. Next slide. So the Swiss cheese model, this is a model of reviewing eras. It shows how there are blind spots and failure modes, or what we call holes, that lead to adverse outcomes in a system. So there are the model, and there are lots of different ways that Swiss cheese has been explained in the past. But this Swiss cheese model can be applied to so many things that we do in our healthcare organizations, from infection control to administrative processes. Multiple interpretations and examples of the model can be found online, but we have one that we really like that we wanted to share with you, and it's a very short video. Next slide.
This metaphor shows us that in a complex healthcare system, a series of defenses.
It's not coming through very clearly.
Perhaps as a defense against things going wrong. Ideally, all structures should remain intact, but each barrier has unintended weaknesses or holes, which are consistent and are constantly opening, shutting, and moving. Hence the similarity with sweet change. If an error occurs and breaks through a hole in one's life, it isn't a big problem, as that usually is a result of the outcome. But sometimes the holes line up in multiple slices, meaning all the defense that is day one. If it is investments into contact with patients, and goes further along. The holes in the defences arise from two reasons: character failures and latent conditions. Failures are unsafe acts committed by people and direct a variety of flaws, slips, lapses, mistakes, and violations. Collective failures have a direct and usually short effect on the activity of defenses. Slips occur when a correct plan is made, but is incorrectly executed. For example, you visit watch the airport, but went into mental order listen to go to work instead. Lapses occur when a step of the plan is missed or forgotten. For example, you had to set an alarm but forgot, so you overslept. But trips occur due to the misinterpretation of a relevant rule.
Oh,
For example, you interpreted your flight check-ins as 8 a.m. was a flight the airport late. Violations occur when a person doesn't follow not any intention to cause harm at the same time or complete a priority task. For example, you left your flights and drove in excess of the speed limit, but the police spotted you in the van. The design and working of the system, environment, or equipment. They may be doing to the system until they combine with an act of faith to create situation latent conditions will cause some of the person loss to defense, ineffective training, inadequate supervision, ineffective communication, and inadequate staffing. Defective equipment, unworkable procedures, and poor design of devices, equipment, or supplies. The system in Swiss cheese model regards failure as an inevitable result of the system and believes that countermeasures should be based on the idea that we cannot change the human condition, but we can change the conditions under which humans work.
sorry, that video didn't sound too well, but the caption was there. But basically, and you can pull up the Swiss cheese model. The information is in there, but it's basically showing that sometimes we think everything is working just right, and that we have everything in line so that there aren't problems, but things do happen. And there are, slips that get through, and when the holes in the Swiss cheese line up that way. So, but it's a really good short example of how the Swiss cheese model works. Our investigation, when we're reviewing events where there was an unintended outcome, it's important to complete that thorough investigation and then put processes in place to reduce the chances of the error in the future. There are 3 key questions to understanding operations. What happened? What normally happens? So how the process currently operates. And then importantly, what should have happened? How the process was designed to work. Usually with those 3 critical questions, we can really understand the operation. Knowing how people interact with the system is definitely key to improving that system for the users. Next slide. So there are 3 what we call breaches of duty. So there are 3 duties. There is a duty to produce an outcome. There is a duty to follow a procedural rule, and there is a duty to avoid causing unjustifiable risk or harm. So the duty to produce an outcome, this system is largely controlled by the employee. So there are rules specific to the outcome that needs to be achieved. And this is applied when the employee is aware that they control the system and is responsible for the output of the system. Duty to follow a procedural rule is largely controlled by the employer. Focus on rules regarding how to perform a job. This path applies when the employee works within the system and is responsible for being reliable and competent in that particular system. The duty to avoid causing unjustifiable risk of harm. This particular algorithm is used when there's potential or actual harm to a person or property. Next slide. So this is just an example, and there are hundreds of different algorithm examples of just culture. They all typically have the same duties listed: duty to avoid causing unjustifiable risk or harm, following a procedural rule, and the duty to produce an outcome. But this is basically an algorithm that shows how you follow that particular investigation with those duties. Next slide. So we're going to start with some case studies, and you guys are going to get to participate. So in this particular case study, and this is based on what we've talked about before, this case study is an emergency team was notified of an incoming STEMI patient. So that is a patient that is having ST elevation MI. In preparation for the patient's arrival, the pharmacy removed STEMI medication from the automated dispensing cabinet, along with medications for a rapid sequence intubation. So as you see, the STEMI medication was heparin, aspirin, and I'm not going to pronounce the other one. The rapid sequence intubation medication, etomidate, succinylcholine, and we used to call it something else, but rocuronium. All of the medications were placed in the medication preparation area in the trauma room. Upon arrival, the patient was coding and required emergency intubation. Airway medications were requested by the pharmacist and administered. So based on the recommendation of cardiology in consultation with the patient's family, treatment was not pursued and STEMI medications were not necessary. Now remember, the STEMI medications were pulled from the dispensing cabinets. Once the patient transferred, it was discovered that the heparin and etomidate vials were the same size and have similar labeling. In the rush to care for the patient, it was discovered that the heparin, rather than the etomidate, had been drawn up and administered to the patient. So the heparin was part of the STEMI medication, and the etomidate was part of the rapid sequence intubation medication. Next slide. So what type of error occurred? Was it a skill-based error, a rule-based error, or a knowledge-based error? Was there an intention to cause harm? And then following a discussion with the staff involved, it was determined that there are aspects of both human error and at-risk behavior. What would be the next steps? What would be appropriate for the next steps? And you can choose all of those that may apply. So consoling, coaching, completing a record and putting it in their file, look for system errors, and then discuss the case in a confidential manner. So you guys choose one choice. What kind of error occurred? Was there intention to cause harm? And then what would you do, choosing all that apply after this particular situation? Okay, so it looks like the participants are saying, and I'm trying to move this so I can see what was the, I can't see the results to number 1, Mike. Can we scroll?
So, results to number 1, what types of errors occurred? looks like the report back here is 1% selected skills-based, 5 of 12, so about 40% selected rule-based, and 6 of 12 selected knowledge-based, so 50% on that one.
Okay, so 50% said knowledge-based. Okay. And then was there an intention to cause harm? 100% said no. And then following the discussion, it shows that the largest majority say coach the employee, of course, and then console the employee, look for system improvements, complete the record, and place it in the employee file, and then discuss in a confidential manner. All right, next slide. Let's see what the case study results said. That this was a skills-based, the pharmacist in the second year of residency training mistakenly used the incorrect vial when preparing the requested etomidate dose in an urgent and chaotic code situation. And no, there was no intent to cause harm to the patient. And then A, B, D, and possibly E. So consoling the patient, coaching the patient, and then coaching the staff, identifying opportunities for improvement with the staff involved, and discussing aspects of the case and potential system improvement in a confidential manner. Next slide. Case study 2, this is a shorter one. There are 2 nurses that select the same wrong vial of an IV medication from the med dispensing system. One nurse administers the medication to the patient and causes cardiac arrest. The other nurse realizes the switch when drawing the solution from the vial into the syringe at the bedside. These were 2 completely different patients. 2 different nurses, 2 different patients. They both pulled the same wrong vial of IV medication from the med dispensing system. Next slide. So was this type of error skill-based, rule-based, or knowledge-based? Was there an intention to cause harm? Following a discussion with the staff involved, it was determined that there are aspects of both human error and at-risk behavior. What next steps may be appropriate? So we'll poll the group and see what you think about this one. All right. So these results, 57% say skill-based, 43 rule-based. There was not intention to cause harm. And then we show console the employee, coach the employee, complete a record of the conversation and put it in their file, and then look for any system improvement to make a human error, improve that human error. So next slide. So it was a skill-based. The nurse inadvertently selected the incorrect medication from the dispensing cabinet. It is a skill-based error. There was no intention to cause harm. And then A, B, and D. So caring for the caregiver and consoling the distraught staff member is important in any situation. Coaching the nurse on the importance of verifying meds prior to administration is a critical component for at-risk behavior. Looking for system improvements such as placement within the med dispenser of the dextrose and lidocaine, and monitoring and override should be considered. So in this particular situation, it was discovered that the medication in question looked like the medication that should have been given in shape, size, color, and name. So this was an error that was waiting to happen. So it was important that you complete a deeper system investigation to determine the root cause. So there were things that could be done to make it harder for this to happen in the future. So we've all been probably involved in look-alike, sound-alike medications that look the same. But there is also that component of we need to make sure that we are able to barcode scan so that we don't, that we have another layer of notification if we possibly have the wrong medication. It's really important that we do use our barcode scanning. And just to kind of piggyback on that, if it's not working appropriately, then we need to figure out why it's not working appropriately. We do hear a great deal of hospitals that say the barcode scanning doesn't work, the barcodes are messed up, or the equipment's not working appropriately. All of those things need to be addressed. So we do have that additional layer of help. It is a layer to help us not make a mistake with medications. Next slide. So case study 3. So during this particular accreditation survey, it was discovered that one of our biomedical pieces of equipment that was examined had some past due maintenance service stickers. So the biomedical equipment database, there is the equipment is all accounted for, and it shows whether or not it's been serviced appropriately. So it's a policy requirement that all the service dates are accurate on the equipment used for patient care. So this was further investigated, and it was discovered that one engineer who works for the biomed department had been forgetting to put the service date stickers on the equipment. And this engineer had repeated coaching. So during this accreditation survey, they found that this equipment was past due on its maintenance, or that's what the sticker said. So next slide. So what type of error is this? Is it skill-based, rule-based, or knowledge-based? Was there an intention to cause harm? And then what steps may be appropriate? And we would choose all that apply. All right. So the largest majority of you guys chose rule-based, and then next was skill-based, and then knowledge-based. Was there any intention to cause harm? And that was the largest majority was no. And what next steps may be appropriate, and choose all that apply. So the greatest number of you, or the largest percentage, was consider a written warning if a verbal warning had already been given. Looking for any system improvements to make that human error harder to happen again, to commit in the future. And then coaching the employee and consoling the employee. Next slide. So the answers to that was, it was a rule-based. The engineer was aware of the rule to place service stickers on equipment to ensure the equipment information matches the system information. There was no intention to cause harm. And it's B, C, and D. Coaching the engineer on the importance of staff members being able to easily identify equipment that's safe to use. And then, of course, is just as important as the database information. It's important to remind the team member that repeat errors can't be tolerated. And so then they said that it was helpful if we could work with the team member to help them create a process to make it easier to complete the process moving forward. Also, one of the options was also to work with other engineers to see how they're doing it effectively and create standard instructions, or what we would call standard work. So if you have other engineers who have this process down pat, that's a good place to start. How is it that they can do it right every time, but this one person is having a problem? So that would be a great opportunity to have another staff member help this staff member do what the right thing. Again, making it easier for everyone to do the right thing. Next slide. A surgical team does not perform a surgical timeout because no adverse events had occurred in the past. This is a well-known best practice in healthcare settings, and the hospital clearly had outlined and defined policy on surgical timeouts and their importance. So this particular team, they're just not doing the timeout because they've not had any problems in the past. Although you know that this is a best practice and they do have a policy. Next slide. So what type of errors occurred? Skill-based, rule-based, or knowledge-based? Was there an intention to cause harm? And it's known that timeouts are hospital policy and clearly defined best practice. So what are the next steps? And then it is later discovered that the provider, the physician, had been pressuring this surgical team to skip timeouts to increase overall throughput. So he just didn't want them to do it because he wanted to get in there and get started and get this work done. The provider brings a lot of revenue into the hospital and had been in practice in the community for nearly 25 years.
I have a question, Carla.
Okay.
Is this case on the physician or the team? So are the questions based on the physician or the surgeon or the team?
On the team. So it's the whole group has not been doing the timeout.
Okay.
The physician pressuring them does have something to do with it, but it's overall. Okay. So you guys said that 83% said it's rule-based, and then skill-based and knowledge-based follow, and they're equal. Was there an intention to cause harm? 92% said no. And then 92% said coaching. And then 83% said consider punitive action. 75% look for any system improvements that could be made, and then 17% console the employees. Next slide. So this was definitely rule-based. The surgical care team knowingly violated hospital procedures, policies, and best practice. There was no intention to cause harm, but then argument could be made regarding the justifiableness of the actions performed. 3 was C and D. The care team knew there were clear policies and procedures in place regarding the importance of timeout. And it is the care team's imperative duty to practice beneficence, I hate that word, in all actions and protect the best interest of the patients. In this instance, the care team clearly violated generally accepted best practices, evidence-based practices, and hospital policy. So given the widespread nature of this issue, the hospital should conduct a thorough investigation and possibly a failure mode analysis to make it harder for system failures like this to occur in the future. They also said that the physician should be called in to peer review. All of our patient caregivers have a responsibility to act in the best interest of patients. Training might be needed for this surgical division, and leadership presence on the unit may need reevaluation, as there could be a deeper cultural issue occurring to allow all parties involved to believe not performing a best practice and hospital stated policy is okay. So in this situation, just because the provider was pressuring that group not to do timeout, the group should have felt comfortable to say, no, we have to do timeout. It doesn't matter whether the provider, the provider has been there forever and does bring in a lot of revenue. This is a best practice. So they should have felt okay to say, no, we're going to do our timeout. Next slide. So this is the last case study. So a hospital noticed an increase in surgical site infections. During this time, the Central Services Department had noticed a change in the consistency of the cleaning material that they had been using to clean surgical tools. Materials management ensured them that the same detergent that they've always received, that's the same stuff. But it was later discovered the detergent had been improperly restocked and shipped to the hospital by a distributor. It was not safe for cleaning surgical instruments. Next slide. What type of error occurred? Was there any intention to cause harm? Staff in Central Services raised concerns to the leaders and to other departments, but were assured that this was okay. Only later did the issue get investigated more intensely once risk management was made aware. So how should leadership respond to the team members? Choose all of those that apply. Okay. So what kind of error? 91% knowledge-based, 9% rule-based. 2, was there an intention to cause harm? 100% no. And then what would we do? What should we do? So 82% both look for any system improvements to help the human error, help the human error to be difficult to commit in the future. And then 82% coaching the leadership team on the importance of investigating team member concerns, coaching the employee at 55%, and then both 27% consider punitive action for the employees involved, and then coaching the, consoling the employee. Next slide. The answers say that yes, it was knowledge-based. The Central Services team really didn't have any way to escalate the issue further up the chain of command. I mean, they had talked to the materials management team about the product, and they had no reason to trust that that wasn't correct. There was no intention to cause harm. And then A, D, and E. There were no fail-safes in place to prevent this error from occurring other than the team member judgment and expertise in the moment. There was no intent to cause harm, and the health system had no policies or procedures in place to address this kind of concern. The manager of the department should be coached to investigate team member concerns more in depth to ensure all proper chains of command are notified. And finally, a system should be implemented in materials management and in Central Services to ensure materials are properly vetted before use on equipment or patients. Next slide. So just to summarize, Just Culture recognizes that competent professionals make mistakes and acknowledges that even competent professionals will develop unhealthy norms, shortcuts, or routine rule violations, but has zero tolerance for reckless behavior. Systems are never 100% reliable, and every event should be viewed as an opportunity to learn. Next slide. So I love this. People make errors which lead to accidents. Accidents lead to deaths. The standard solution is to blame the people involved. If we find out who made the errors and punish them, we solve the problem, right? Wrong. The problem is seldom the fault of an individual. It's the fault of the system. Change the people without changing the system, and the problems will continue. Next slide. We have a few minutes here for some discussion, comments, questions. If you're on your Just Culture journey, if you want to share anything that you have seen in your organization, or benefits or barriers or concerns, that would be great too. But I will open it up if you want to put something in the chat, or if you want to unmute and then speak out. That's great. Now, I know with all of you on here, somebody has something to say.
I will start off. I will tell you, Carla, just culture is such a foundational piece to keeping everyone in the hospital safe, including the staff and the patients, of course. And so I think this was an exceptionally important message to relay, and I've seen it firsthand in the hospital setting as a on the patient side, and on the patient safety side. I think it's exceptional information that you've shared today. So I hope people, just culture takes a while. It takes a while to really form, and it starts at the very top of the hospital. It starts at the top end, because if you don't have support from the top end, the management levels below struggle to make things happen or make things work. So I've seen that, and I wonder if we have some leaders on the call today who have some thoughts about that.
Absolutely true, Denise. Anybody?
They didn't know I'm gonna forward a test to them after. So everybody on the call, you're getting a test soon. I won't do it.
Well, and it's really important, because if we do establish a culture within our organization where everyone feels comfortable to report near misses, more that, there are so many places that I've heard, well, we don't really report near misses. We only report things that happened. Well, a near miss is something that's going to happen. So if we do have a near miss, that's a great opportunity. I mean, we should be thrilled that we can report it, because it hasn't happened, but it's the opportunity for us to fix a broken process before something does happen possibly, and it hurts someone, and it does cause harm. So we need to have a culture that is comfortable reporting everything. In that, and that's the only way that we can make change. If we don't know that it, was happening, we can't make the change. And our leaders aren't at the front line. Our front line need to be comfortable to report.
Yeah, I agree. And I have seen the surgical case study. I've seen that one firsthand. And the team was being pressured by in a hurry surgeon. They were wanting to go, get it done, go through, quick. Mm-hmm. And the team did not speak up. And that was a big indicator that in that culture, in that surgical suite, they were having a problem, because the team couldn't speak up and say, we've got to do the timeouts. We've got to do these. We've got to do the counts. We've got to do the timeouts before we start. And we have a message in here from Crystal. She says we have a great catch campaign that she's implemented, and it's encouraged staff to report those near misses, which is excellent. I love great catch campaigns. Yeah.
That's great. That's great. Yeah, I had a same situation. I had a provider who, when I was an endoscopy nurse, a provider that wanted me to roll the patient into the endoscopy suite and start the medication we were using at the time for sedation was fentanyl and Versed, and he wanted me to start that before he entered the room. That's completely against policy, and it is not best practice. And he became very angry that I would not do that, but I just was not going to do it. I mean, it's unsafe, but the providers can be very pushy. And for especially new nurses, that's very intimidating. That a provider is telling you to do something, or they don't want to do something that is following policy. But we all need to feel comfortable in our organization to speak up and say, no, that's against our policy and our rules and against the safety, for the safety of our patients.
Yeah, and the staff has to be knowledgeable enough to know those policies. So there has to be that education on those policies and that education on speaking up and knowing that you're right. So you're right to speak up. And that's another piece of that too, education.
And that's why it should start at orientation. This is our culture in our organization, and you feel comfortable with that.
Well, I don't hear anymore. I feel like and the chat box has gotten quiet. So I'm going to just stop right now and say thank you, Carla. Excellent presentation like always, and we're so appreciative of your expertise and guidance in these really important topics. So appreciate you.
I appreciate the opportunity, and my information is also on the slides. If anybody has any further questions, I'm available.
I appreciate that. Thank you so much. All right, everyone. So as we did at the beginning of the presentation, we're just going to do a short poll. Mike will now pull up the polling questions. They'll be kind of done on the same confidence scale as the ones from earlier. And it just helps us to measure knowledge gained on today's webinar. So if you can go ahead and do those on the from confident to unconfident scale, and then we'll get the results and we'll see if we can measure some change today. I know it was super informative, and I'm just so grateful to have that knowledge and expertise at our fingertips, and for us to help guide all of our process improvements. All right, so I'll give just another minute, maybe a moment, get that done, and then about another 10 seconds, and Mike, you can close that poll, and then we'll get the results. Here they come. Well, we are now with on number one, we are at 50-50 on confident and somewhat confident, but we've lost all of the other options there. So no more on the neutrals or unconfident. We are 50 and 40 and 10 on the next question. And we are at 80 and 20 and lost all of those other options there. So that was some great learning. And then number 4, we have 70% are confident they can apply this knowledge. So that is excellent. I appreciate that so much. Thank you all for participating in the polls and in this presentation today. It concludes today's webinar, and we hope you found it informative and that it provided some useful new perspectives, ideas, and best practices to begin looking at. So again, thank you for attending and have a great day.